All right. I know some people are still jumping on here, but I wanted to welcome everyone to our clinical insights talk into hantavirus, the diagnosis, treatment, and emerging trends. We have an awesome guest today who's going to provide some kind of cutting edge and clinical insights into the diagnosis and treatment and management of hantavirus. But before we do that, I want to acknowledge our sponsors for the talk. So Northern Inyo Healthcare District, Mammoth Hospital, both Mono County and Inyo County Departments of Public Health and Environmental Health as well. And this talk comes on the heels of a recent community talk that we held about 2 weeks ago, where we had around 200 people listen to the talk live, and then we've since had about 250 people view that discussion on YouTube as well. So this has been hantavirus has been a hot topic in our community for years, but especially over the last couple of months. So with that in mind, I'm going to introduce our speaker today, and we'll get started. So we are lucky to have Dr. Gregory Mertz, who's a professor emeritus of internal medicine and the former chief of infectious diseases at the University of New Mexico. Dr. Mertz is a nationally recognized expert in hantavirus research and care with more than 2 decades of National Institute of Health supported studies in Chile. He will provide insights into the clinical presentation of HPS, current diagnostic and treatment strategies, and emerging research on this rare but often fatal illness. Before we have Dr. Mertz start his talk, I did want to introduce Dr. Tom Boo, who's the Mono County Public Health Officer. Dr. Boo has also practiced primary care medicine and provided primary care treatment to our communities for multiple decades. And Dr. Boo, maybe you could start us off by providing a little clinical update on the communities and the exposures to hantavirus that we've had in Eastern Sierra recently.
Yeah, thanks, Dr. Hawkins and Dr. Mertz. Tom Boo, Mono County Health Officer. Yeah, we had 3 human cases of hantavirus from the town of Mammoth Lakes, all unfortunately fatal, and all with onset in February of this year, which is really unusual and quite concerning. And that was the catalyst for holding the community forum a couple of weeks ago that Dr. Hawkins mentioned, and also was the reason that I reached out to Dr. Mertz to kind of just get us all up to speed on hantavirus, because it's endemic here in the Eastern Sierra. We have the highest incidence rate in California, but it's not common, and many of us will never see a clinical case in our career. But if we do, it's a good one not to miss. So again, thank you very much, Dr. Mertz.
Thank you, and thanks for inviting me. I'm going to put up this first slide. I would suggest you either take a screenshot or a picture of this with your camera, because I'm going to come back to this slide at the very end. But so this is a 35-year-old male from a rural region in the western U.S. with no history of exposure to mouse droppings, presents to a small rural hospital with a history of 4 days of fever, headache, and myalgias, followed by onset of cough and shortness of breath. Blood pressure and heart rate are normal, O2 sats 85%. Their bilateral pulmonary infiltrates, CBC reveals a hematocrit of 60, platelets of 40,000, white blood count 20,000 with left shift, no toxic granulation in the polymorphonuclear line. Smear evaluation for immunoblasts is pending, and the question is, what is best practice? And hopefully you've had a chance to screenshot or use your camera. Everybody has a smartphone, I'm sure. So next one, New York City resident with fever for 3 days, thrombocytopenia, normal oxygen saturation, and no cough, presents to an urgent care center in New York City. He reports visiting your site for 48 hours, where he slept in an abandoned cabin after sweeping up mouse droppings. And then you have a couple different scenarios, which we can discuss at the end. One is that this happened 5 days ago. The next is that it happened 7 weeks ago. And the third scenario is it's 4 weeks ago, and his brother just died from hantavirus at a hospital near his home in Chicago, let's say. So everybody have a chance to look at that and think about it. Okay. Oh, sorry, I'm having problems with obviously with the slides. So there are two primary syndromes associated with hantavirus infections. On the left is the syndrome that's seen in the Americas, which we prefer to call hantavirus cardiopulmonary syndrome, to really try to remind people that it's cardiogenic shock that kills people in the hospital, and usually it's not hypoxia. And then the other syndrome is hemorrhagic fever with renal syndrome, which is seen in Europe and Asia. Um, so in both cases, the virus is transmitted from mice to humans through aerosolized viral particles shed in the rodent's urine, feces, and saliva. Uh, but the clinical manifestations in humans is different. And here, the little rodent on the left is Oligorhizomys longicaudatus, which is the primary host for Andes virus. So I apologize. There's something in the system that's moving my slides without me wanting to. So this is the number of cases in Eurasia is much greater than in the Americas. But as I'm sure you're aware, the case fatality rates at least in North America, and then in Brazil, Chile, and Argentina are much higher than the case fatality rates for any of the viruses that cause disease in humans in Europe. And the main pathogen that we need to focus on today is Sin nombre virus, which occurs in the Western United States. And I'm going to talk some about Andes virus because we've done a lot of research there, and I'll explain why Andes virus, why we were able to get funded for studies in Chile, and why the studies we did there turned out to be so illustrative. This was the site of the first case cluster of hantavirus cases in New Mexico in May of 1993. That's when I first got involved, where I was chief of the infectious disease section at University Hospital at that time. And two individuals from this small village in western New Mexico. Both this was a Navajo community, and a young man and a young woman who were actually elite distance runners became ill and presented to different emergency rooms in the Indian Health Service system within a few days of each other, and unfortunately both died. And when Bruce Tempest, who was a longtime infectious diseases consultant at Gallup Indian Medical Center, investigated the young man's death, he heard about his partner's death and was worried initially about whether this might have been a pneumonic plague with person-to-person transmission. So an investigation was initiated at that time. Subsequently, of course, we recognized the disease throughout the United States and then throughout the southern half of South America. And you can see the states with the most cases include Colorado, New Mexico, California, and Washington. So these are and most of the cases you can also see are have occurred west of the Mississippi River. So for the New World hantaviruses, most infections are from an inhalation of infected rodent excreta. There's no vector. A common story is people enter a shed or a home that's been closed for the winter. Sheds opened up. Person walks in without taking precautions, and then and then weeks later develops illness. There's also rare transmission from rodent bites, just a handful of cases in North America that I'm aware of. There was a case report of two boys that I think that caught some mice in Kansas, I think, and mice bit them, and weeks later they developed hantavirus. There's a lot of interest in Chile and Argentina on Andes virus because one is more common disease in South America than in North America, but also because unique to all the hantaviruses we know about in the world, there's person-to-person transmission. So in one study, we showed that sex partners and other close household contacts were at the highest risk. There have also been super spreader events in Argentina, where there have been large numbers of cases, where person-to-person transmission is clearly the cause. And then rare nosocomial transmission has been documented in the hospital in Chile. And then I mentioned as we were setting up today that there's also been maternal neonatal transmission, probably in breast milk, and a few cases in Chile. The incubation period is clustered around 30 days, or I would say 3 to 4 weeks. In 10 infections I acquired at Yosemite in 2012, where there was limited exposure in these cases, like just up to 72 hours of exposure. The range in incubation period there was 20 to 49 days. So in that case, 3 to 7 weeks. And then in Chile, in cases where people were visiting endemic areas in southern Chile for a few days, and then returned to Santiago, where they became ill, where there was no known transmission occurring. The incubation period there ranged from 10 to 34 days, and the average was a little less than 3 weeks. In Argentina, the median incubation period 20, so about 3 weeks, in 15 cases of person-to-person transmission, in a report by Wells et al. In 1997. Median incubation of 19 days, so almost 3 weeks, and 14 cases of person-to-person transmission in a prospective study that I'm going to describe to you. And then a median of 33 days, incubate range 9 to 40 days in 33 cases of person-to-person transmission in a series in Argentina published in 2020. So it's hard to get this information. In most cases, we don't know when the exposure occurred because someone's living in a home, and we later find that the home has been infested with the rodent that transmits the disease. So we don't really know when it occurred. But in these 5 papers, there's really very solid evidence of transmission. And you see it's rarely. Here's I think the lowest number of days here was 9, and the greatest number was 49. It's probably a little bit on each side of that, but but I think we have a pretty good idea. In most cases, they're going to occur in 3 to 4 weeks. The Yosemite, I don't know if any of you reread the Yosemite outbreak report recently, but there were 10 cases. Age 12 to 56, and they were all visitors to Yosemite. They came from California, other parts of California, West Virginia, Pennsylvania. There were 3 deaths, incubation period 20 to 49 days. So 3 weeks to 7 weeks, and 9 of 10 of them acquired an infection in the Curry Village signature cabins. And I'll show you a picture of two of that. So these are the signature cabins that had been built. They put insulation on the walls of these cabins uh, a few years before the outbreak in order to extend the period of time that they could rent the cabins. And in so doing, they provided some nice nesting material in the walls of these cabins where the deer mice like to form nests, and this led to the outbreak. And then these are the incubation periods. And I just mentioned, in addition to this report, I was involved with some of the legal cases that followed this. So I was actually able to independently review records that included the dates when these people were rented the cabins and then all the hospital records from when they became ill. And these dates are really solid. I think so. I mean, whether like that 49 day, I think that maybe that could be a 51 day or maybe a 48 day, but that's these these numbers are not off by more than a day or two from what I was able to determine in my review. And then in before all this occurred, we began a NIH-sponsored study in Chile that was prompted by recognition of the first cases of hantavirus in Chile in 1995, or excuse me, 1997. And I went to Chile in 1997 and took this picture. This was a home. This is as close as we got to this home, but this was a home where one of the first cases had acquired disease. This home had been boarded up over the winter, and then the people came back in the spring and opened up the home, went inside, started sweeping up and cleaning, and then a couple of cases occurred a few weeks later. And why Chile? How were we able to justify going there? Well, we didn't have this much data when we wrote our initial grant application, but just looking here at 6 years at the number of cases in Chile per year, where you have here like 40 to, excuse me, go back. You've got 40 to 65 cases in Chile as compared to maybe 18 to 39 or 40 cases in the United States. And then if you look at this in terms of adjusted for the population, you see that in Chile over this period of time, you have average of about almost 3 cases per 100,000 per million population in Chile as compared to 0.01 cases per 100,000 in the United States. So it's a place where focusing on on few critical regional hospitals, you're much more likely to be able to enroll cases than you can you'd have to set up many more research centers in the United States to catch a smaller number of cases. So that was one of the arguments we used. They also have we know that the number of cases vary by year in both in North and South America. If you look in the United States, the epicenters for cases in the United States move around depending on weather patterns and food availability for these rodent hosts. One of the things that happens in Chile is that every 50 years there's a bamboo tree that blooms and drops tons of seeds on the ground, and then you have a population explosion in this that they call a ratada. And I just like this picture. This is a picture of a beach in an area in Chile where there are a lot of cases of hantavirus, human cases of hantavirus occurring, and these are mice, many of them probably hantavirus infected that have outgrown the food, or the population has outgrown the food in their territory, and they've tried to swim across this freshwater lake to find more food, and they drown and get washed up on the beach. But it's a pretty kind of gross, but also an illustrative picture. So we set up in yellow, you can see all the provinces or the regions in Chile where hantavirus cases have occurred in humans, and you can see the hospitals where we set up within that region, the hospital where we set up research sites, where we would have a physician investigator, uh, often a critical care physician or infectious diseases physician at each of these hospitals, and then a research nurse. And we had funding through the NIH to reimburse them for the cases that they were able to enroll in the studies that we put together starting in the year 2000. And this is my favorite study from that period. This is a very busy slide from the Journal of Infectious Diseases. But we enrolled, so we enrolled 476 household contacts of, I think it was 76 cases, index cases. So when a person would come into the hospital with hantavirus infection, we would ask them if they lived in a home with other individuals, husband, wife, children, aunts, aunt, whatever. And if there were other people in the household, we asked to enroll their household contacts. And then we sent research nurses out to the homes weekly for 4 weeks to draw blood on them. And then at the initial visit, we did a very detailed history from the exposed contacts to see what kind of contact they had with the index case. So what did we find out? Well, if you just look at the relative risk here in the third column, if you're the sex partner, relative risk of 15. If you slept in the same bed, and we had people that became ill that slept in the same bed, like a 2-year-old that were not sex partners but acquired disease. Sorry. Then, and if you look exposure to saliva deep kissing, that's also a risk. And then if you look at sleeping in a different room, that's actually statistically significant to be protective against getting hantavirus. So sleeping in the same room or same bed increases risk. Kissing increases risk. Sleeping in a different room significantly decreases risk. So all this is kind of pointing toward close contact, but not requiring sexual contact. The other thing that we were able to do is that because we were obtaining blood weekly from these individuals, we were able to identify what's happening prior to the onset of clinical disease. So off here on the right in orange are people that are having the prodrome. So they have some fever, muscle ache, and so forth. And when they're in the prodrome, so in the prodrome, they have their PCR positive, they're IgM positive, and they're IgG positive. So they have antibodies. However, prior to the prodrome, so in the first couple of weeks here, they're RT-PCR negative, antibody negative. In this dark color gray here, or whatever, so they're PCR positive, but antibody negative. So we're actually able to show that for up to 2 weeks prior to the onset of symptoms, prior to antibody being present in these patients, that we can identify hantavirus RNA in their blood through PCR. Boy, this is really frustrating. So just to look here, this is a schematic sort of summarizing all of that. So we're saying during the incubation period here, with both diseases, we think there's viral and RNA in the blood, and that probably peaks, that's present. And then during the prodrome, you've got viral RNA. Later in the prodrome, you've got antibody present. The virus peaks in the blood during the disease and then falls off, and then eventually you have IgG that persists for life. Uh, Clinical, so in the prodrome, there's fever, myalgia, headache, backache, abdominal pain, vomiting. Some or all will be present. There's no cough or shortness of breath. At the onset of disease, you have bilateral infiltrates and respiratory failure, and then the severest disease, shock. Laboratory findings, thrombocytopenia starts during the prodrome. Proteinuria is present, increased hematocrit at the onset of the cardiopulmonary phase in the severe cases, immunoblasts present during the disease, LDH going up when you have the lung disease. And this is a typical pattern of someone here. This is initial chest X-ray. They came in with very early findings here, progressed to bilateral infiltrates, and then even further with bilateral infiltrates. And then interestingly, with this disease, there's rapid, if they're going to survive, they had rapid clearing. And our pulmonary critical care specialists early in 1993 were saying that someone, I think this was called unexplained ARDS for a while by the CDC, and our pulmonary colleagues were saying this isn't ARDS. The ones that don't die have recover over like one day. We're extubate, they go from requiring extra mechanical ventilation to being extubated in one day, as opposed to the gradual improvement over weeks with ARDS. And that's been also borne out in the fact that this is a capillary leak syndrome and a cardiogenic shock syndrome, and not a syndrome resulting from diffuse alveolar damage like you see with ARDS. So just to summarize, IgM and IgG antibodies appear during the prodrome, RNA detected in blood up to 2 weeks before onset of fever, up to 90 days after recovery. There's viral antigens by immunohistochemistry in tissue. So that's one of the ways on autopsy you can establish the diagnosis. And then isolation of hantavirus from humans is really difficult. There's one case that I know of, it's from Chile, where a boy came into the emergency room, had some blood drawn, I think, and was sent home. Came back a few days later to the emergency room and died. We went back to that initial sample that occurred, and there was no antibody present, but we were able to detect hantavirus. We were able to actually detect hantavirus by PCR, and we're able to cultivate it. So, clinical recognition. From this case series in Chile indicate that more than half of patients seek medical care during the febrile prodrome, but are sent home. And there are actually there's two case series, one of which we've published and one of which we're working on publishing now, that show the same thing. 55 to 70% of cases are sick enough during the prodrome that they seek medical care. But the disease looks like many other non-specific, or it looks like many other viral diseases that resolve on their own. And because it's not distinctive during that period, and because the disease is rare, they tend to be sent home. So most patients are admitted from when they seek care at the onset of the cardiopulmonary phase, and then a presumptive clinical diagnosis at that point can be made on the basis of symptoms, hypoxia, bilateral infiltrates, and then the CBC and blood smear evaluation that I know many of you are aware of and have been learning about recently, or had been aware of in many cases for some time. So this presumptive clinical diagnosis can be done quickly, like in at least most of it within as long as it takes to do the CBC and blood smear. The thing that can hold it up is that you need someone who's familiar with the immunoblastic morphology to look at that. So sometimes in the heat of the hour in the emergency room, you may be left just with thrombocytopenia, elevated white count, sorry, um, left shift with immature uh, uh, white blood cells, lack of toxic granulation, and then if you're lucky and the patient's not lucky, you can see hemoconcentration. So in the sickest patients, you may have these four before the lab has had time to have someone look for these immunoblastic morphologic features. So not good for the patient to have hemoconcentration because the sickest patients do, but you can make this diagnosis, the presumptive diagnosis, on things that you can get back very quickly. And these are the immunoblasts that the hematopathologists and hematology techs can identify. So in Chile, one of the things that we noticed early, this is from the first 100 patients that we had looked at, or maybe just shy. I think the current data set has just has 22 patients in this set. But looking at it a little different way, if you look instead of hospital day at the number of hours since the patient hits the emergency room, basically 16, I think it was 16 of 22 deaths occur within 24 hours. So the majority of deaths occur very quickly. And we saw the same thing. This is a placebo-controlled trial of ribavirin versus placebo that I led in the first 10 years or so. The disease, this is in US and Canada. We had a terrible time enrolling patients that actually had disease. We tried enrolling patients during the prodrome. We enrolled patients. Some of them got ribavirin, some of them got placebo. None of them had hantavirus. So we weren't able to identify patients in the prodrome for enrollment in our study. And I know we still struggle with that. But if you come in the cardiopulmonary phase, this clinical diagnosis can allow you to enroll patients in a study, or I would argue now, get them to ECMO as quickly as you get them to a center where ECMO is available as quickly as you can. Then you're going to benefit the patient. But again, in this study, you can see that look here at the first 24 hours here. We've expanded. So the first 64 hours are expanded here on the left, and then it's out to day 28. You see that almost all the deaths, or the majority of the deaths, are occurring within 24 hours, and then you have a few more up to 64 hours. And then I think it's actually, so then we just have at 64 hours, we have one death. At 2 days, one death. But the number of deaths occur very quickly after the patient hits the hospital. So you don't have much time. There's another survivorship analysis from a study we did evaluating methylprednisolone versus placebo, and we did this in Chile. In this case, we were able to hit our target enrollment. And the 2 points from this slide is, again, most of the deaths are occurring within a day of hospital admission, or in this case, randomization, which is occurring several hours after hospitalization. And then the second point of this trial is that the SOFA score at entry predicts outcome, but treatment had no impact on outcome. So the treatment was ineffective, but If you've got a high SOFA score, which is a score that the intensivists use for severity of illness, at entry, at end of the study, your prognosis is bad. And if you're seeing patients in the emergency room and you can make a presumptive diagnosis and you want to use a SOFA score, you can kind of predict who you need to just be on the phone with incessantly to try to get them to a to access to ECMO. So ECMO it's for refractory cardiogenic shock or inability to oxygenate blood with a ventilator. Mostly it's instituted for refractory cardiogenic shock. At UNM Hospital, we had 54% survival in 26 patients treated from 94 to 2000, managed with intubation when hypoxic and ECMO for refractory shock. And then we changed to try to electively insert vascular sheaths as soon as we made a presumptive diagnosis. So they didn't need to be in shock. We just had to have this presumptive diagnosis, which is hypoxia, abnormal chest X-ray, and the blood smear findings. Get the vascular sheath in, get them next to the ECMO machine, and then if they don't go into shock, they never go on ECMO. But we had 80% survival in these patients, so better survival if you have ECMO available to them. That's what it looks like. That's what ECMO looks like in our ICU. This is the schematic on, there's a venous catheter, an arterial catheter, primarily with, if you're treating shock, you have to use veno arterial ECMO to both oxygenate the blood and maintain cardiac output. So go back. So hopefully you all remember this patient, and I'd just like to open this to discussion now. I hope people are willing to speak up. I don't have one of those things where you can pick various choices, but maybe if someone would like to unmute. So again, this is a 35-year-old male from a rural region in the western U.S. with no history of exposure to mouse droppings, presents to a small rural hospital with a history of 4 days of fever and headache and myalgias, followed by cough and shortness of breath. He's not in shock. O2 sat is low. Their bilateral pulmonary infiltrates, CBC, shows an elevated hematocrit, so hemoconcentration, thrombocytopenia, white blood count with a left shift, and no toxic granulation in the polys. So smear evaluate. They've called the hematopathologist who lives in I don't know where the hematopathologist is. This case came in at midnight. The hematopathologist is about a 30-minute drive. And they're kind of discussing whether they can go on Zoom to look, whether they can look over on Zoom at the or whether the hematopathologist is going to have to get dressed and drive in. So that's kind of what's happening. So but you're sitting there in the emergency room with the patient. So what are some thoughts?
I think just for the audience, I don't know if you're able to unmute, but we do have a Q&A box.
Is there a way for them to raise their hand and get unmuted, or?
Barb, are you aware? Are we able to
Yes,
open it up to the
they
audience?
can raise their hands.
Awesome.
Okay. So who's brave? Do we have any?
I don't see anyone raising their hand, so I can take a stab at it. Or there's David. David, see if we can unmute.
Yeah, so I mean, hi.
Hi,
yeah,
David.
Hi.
You're
This
very
patient
brave.
they definitely look and sound like they could have Hunt. It looks like the peripheral smear would be 4 out of 5 positives. So, given the clinical scenario, my suspicion would be increased that this is somebody who has hantavirus and is shifting from the prodrome into the acute cardiopulmonary phase.
Okay. So can you uh so where do you practice?
I'm a hospitalist in Mammoth.
In Mammoth. Okay. And my understanding is, so what's your goal now with this patient? First question, do you want to wait for the hematopathologist or do you want to do something else?
No, I think at this point, if 4 out of 5 are positive and the clinical scenario looks like acute cardiopulmonary syndrome, given our limitations, I would want to try to transfer this patient to a larger hospital that has more aggressive, ability to support the patient, whether
Okay.
it's up to Reno or elsewhere.
Okay. And does Reno have ECMO?
They do in at least one hospital that I'm aware of.
Okay. And do they have a mobile ECMO unit?
I don't believe they do.
Okay.
Dr. Mertz, Renown is the big hospital system in Reno. They just actually started an ECMO program this year. So they have
Uh,
2 ECMO machines and are able to do adult ECMO, but not pediatric. I think they've ordered at least 3 more because they've kind of blown by their projected utilization of those machines. So that's the closest adult ECMO center for us.
okay.
And no mobile ECMO units in the area.
None in the area. Okay. So I'll tell you kind of my thinking. So for you, if you had a, so, and one of the places I'm coming from is, since I've published in this area, I get asked to do medical legal review. Did medical legal review for the Yosemite cases. I've been involved in a number of other cases. It's not uncommon for a patient to be transferred. Uh, you're in this setting. A couple of things often happen. One will be a trap you didn't fall into, which is waiting for the immunoblast evaluation or in one case I looked at, there was the hematology tech said there were no immunoblasts, and then later, I don't know, it may have been days later, uh, I think it's a couple hours later, it was changed. The hematopathologist came and looked, or a pathologist. They probably don't have a hematopathologist at that hospital. Came and looked and said, "No, I see immunoblasts." In any case, it didn't change the course in that situation. But the question that I would ask is if a mobile unit's available, whether you can get the vascular access and be next to a mobile and next to an ECMO machine faster if you send the patient there versus having the mobile unit fly to you. If the mobile unit, in your case, the ECMO center may be an hour away by plane, and the center with a mobile ECMO unit may be 2 hours away. So you're going to want to pick the center where the patient actually gets into physical proximity to the ECMO machine and to vascular access the fastest, whether it's transfer or them coming to get you. And these things change. It's expensive for the systems to maintain these systems, so it's you have to kind of try to keep up to date. There is, I think later I think I have a site where you can get the latest information on what ECMO is available closest to any place. And I don't care where you are. Uh, you could be moonlighting in South Dakota or something. This site would still be helpful to you uh, in finding the closest site. So the next one is so New York City resident with fever And for 3 days, thrombocytopenia, normal oxygen saturation, no cough, presents to an urgent care center, reports visiting Mammoth, California for 48 hours where he slept in an abandoned cabin after sweeping up mouse droppings. Sounds terrible, right? Okay, so for A, what do you do in case A, this occurred 5 days ago, that he swept up the mouse droppings, and he's had fever and he's had fever and symptoms for 3 days. What's your thought about this patient with that swept him up 5 days ago?
So again, I'll take a stab at this one, Dr. Mertz. And this is also, it's a comment, it's a question disguised as a comment. But my understanding is that the 5-point CBC screen that you went over is really only helpful when they're transitioning from the prodrome into
in the cardio. They have to be in the cardio. You got to have fever. Excuse me. You have to have hypoxia and bilateral infiltrates.
And I think
in order for you to do that. So actually in none of these, so your point is well taken. So in none of these three scenarios is the smear evaluation going to be helpful. You've got the thrombocytopenia. That's all you get at this point. And having someone look for immunoblasts isn't going to help. My point on this one, unless you want to point on the 5 days, is it's too fast. So, someone calls you, I have urgent care center calls you, you're on call for your critical care unit. Patient was cleaning a garage yesterday and saw mouse droppings, and they had, and now they're sick. And had they been in that, now if they've been sweeping that garage, if they've been in that garage for weeks off and on, then maybe it's a big deal. But this guy he's only been in that cabin for 2 days, and he's been sick for 3 days. So it's too fast. It's got to be something else. So you got to have, at some point, you got to say, oh, okay, this one I don't need to worry about. What about 7 weeks ago? And these are supposed to be hard, or especially this one. But 7 weeks ago, what do you think about the so David raised his hand again, I think, or maybe not.
Yeah, there's David.
Yeah, so it's 7 weeks from exposure. I mean, it's at the long end of the incubation phase, but it could be possible, is my understanding.
Yeah. So yeah. Now what you do, so that's and that's exactly the answer I was looking for. What you do beyond that is tough. Because I'll tell you that this could be hantavirus, but it probably isn't. And how many of these, so the question is, how many of these patients do you want to refer to you're going to send him to an ECMO center now? I don't know. Or are you going to watch him in your center follow his platelet count? And I don't know the answer beyond that. It could be, but probably isn't. And then the last one, so the exposure 4 weeks ago with his brother who just died from hantavirus. What do you want to do with this guy?
I think this scenario is much more concerning with if he's in the week. I guess we don't know if was he with his brother?
Yeah, they were both
with his brother.
Then
I'd be much more concerned.
This guy, for me, this guy goes to the ICU in a center with ECMO. Okay, He's got he can this one so anyway, what do you do then? So if if you've got presumptive diagnosis, you're the you got presumptive diagnosis based on the history of a prodrome, the hypoxia, abnormal chest X-ray, and your consistent CBC and smear evaluation. Insert arterial and venous catheters. Keep ECMO at the bedside. Keep your team at the bedside. Don't wait. You don't wait for shock, because when they go into shock, it's hard to get the catheters in. Once they have an arrest, if they go into a shock, they can arrest I've seen people arrest within like 15 minutes of going into shock, like where I'm sitting at the bedside, and they just can't get once they're in cardiac arrest, getting the catheters in, getting them back is very low yield in terms of getting them back. Suspected or presumptive hantavirus in the cardiopulmonary phase in a center without ECMO, contact the center immediately to determine whether transfer to the center or mobile ECMO will result in the fastest access. So you just got to figure that out by sight. And then at the bottom left here, I've got this ELSO Worldwide Directory of ECMO and ECLS centers. They've all got people on call. They're available. It's really this is a great reference to have to call and get advice. And then, oh my goodness. And then for patients where the prodrome is in the differential diagnosis, I think best practice is unclear. Thrombocytopenia is relatively sensitive, but it's insensitive, but it lacks specificity. And most people that have a febrile prodrome in a rural center and are thrombocytopenic don't have hantavirus. I got something else. And do you send them? Do you send everybody? I don't think you can. Should you watch some patients? Yeah, I mean that 7-week person with not much else, maybe I'd watch that person. The guys whose brother probably had common source infection, hell, I'd send him right away. So the value of the exposure history kind of varies. We really need point of care testing, a 15-minute test that can be done in emergency rooms. But who would pay the money? Which company would pay the money to develop that test? And I'm afraid the answer is nobody. So, and then the last one, I think this is my last slide. If exposure to a pathogen such as Hantavirus virus is documented or suspected, provide guidelines for seeking care at an ECMO center if fever develops. So if someone's calling you and they had a strong history of exposure, but they haven't developed symptoms yet, I would tell them what the incubation period is, and to stay physically near a city where ECMO is available and know which hospital to go to. And this came up. We had discussions after the people went in went into the home where Gene Hackman and his wife had died, and then they went into the outbuildings where they saw mouse droppings, and whether any of those first responders had exposures, and then what kind of counseling to give those people. And then sometimes they're really high risk exposures, such as laboratory accidents, potentially bioterrorism, where maybe you could monitor people by PCR. I've only done it once in a nurse where there was a plumbing accident and a patient on ECMO and with hantavirus, and she was sprayed in the face with the patient's blood when the connection came undone, and we monitored her by PCR for I can't remember how many weeks, and then there was a case at USAMRIID where somebody had a needle stick from a virus that was genetically a chimera between Hantavirus virus and Andes virus, which really sounded terrible. And we had to come up with a monitoring scheme for her. So I was a part of a group that advised on that. And she never got sick, but anyway, I think that's it. I'm happy to answer questions.
Yeah, thank you so much, Dr. Mertz. I know that was super helpful for me. There's some questions in the Q&A box, and then I think there was a couple bouncing around in the chat that Dr. Boo, I know you were addressing as you could. But if anyone, I'm happy to maybe read some of these questions through the Q&A.
Yeah.
But also, if people want to jump up and raise their hands, we'll get to you as well. So it looks like I know Dr. Jepson has a question here with their hand raised.
Hey, Dr. Mertz, this is Sam Jepson. I'm one of the ER physicians down here. I was just curious if there was any data on the timing of intubation, if like intubating earlier or waiting
We
until.
we try to delay. I sort of rushed through that slide, but the impression of our ECMO and critical care physicians is that intubation seems to trigger shock in some patients. So we try whenever feasible to, much as we had tried to learn to delay intubation in COVID, we try to delay intubation as much as possible and try to get the vascular catheters in for ECMO before intubating.
Okay, perfect.
Can't
That's
always
helpful.
do
Thank
it,
you.
but yeah.
Okay, thank you.
Greg, can I ask too, along those lines? I've read that IV fluid can be dangerous, that hydration needs to be judicious. Would you touch on that?
Yeah, that's part of the critical care management. I'm sorry, and I didn't, for somehow I don't have that in my slide, but we use, and I think someone had been circulating a slide that we had developed with a decision tree, and we try to avoid giving fluids once you think about this, and preferentially use pressors to maintain blood pressure. Same idea too. It seems like if you just flood them with saline, they're gonna it just goes into the lungs and worsens the respiratory function.
Dr. Mertz, I'll read a couple of questions from the Q&A. One attendee asked if there's any idea why hantavirus cases aren't more common east of the Mississippi, given the fact that there are some cases documented on the East Coast.
I don't know. I don't have insight on that. Other than, we must have more. I mean, we have the Sin-Nombre virus is seen in the eastern United States. So I don't know enough about the rodent ecology to know why the infected rodents aren't coming in contact with humans there as much as they are in the western United States. So wrong. Unfortunately, not my deal.
There's another question related to. The question is, we transfer patients via airplane, which is true for both Inyo County and Mono County for the most part. And the question is, would this ever be contraindicated due to their cardiopulmonary complications considering the altitude? And I'm assuming the question is,
you got to get them to ECMO. The old literature for years, if you looked at the textbooks written on the textbooks said don't move the patient, don't transfer them, just get them, do your best at the hospital that they're at. You got to get these patients you got to get them to an ECMO center.
Yeah, we have that conversations with our flight team a lot for various time-sensitive things. I'm like, they might not be stable right now, but they're the only chance they have to survive is getting
right.
To a different center. So, David asked a question. So the question is, TNF alpha and interferon gamma are believed to increase lung capillary permeability in HCPS, contributing to pulmonary edema. Is there any role for using TNF inhibitors like Remicade or Humira to decrease progression of pulmonary edema to
No
treat
idea. No
respiratory?
idea.
No idea.
And the CDC investigators were really big on administering steroids to these patients, and this was when hantavirus was first uh, identified in Chile in 1997, I guess it was. And I mean, there were cases in 95, but they were retrospectively diagnosed. Um, the the so there was so it emergency room critical care physicians in Chile started using steroids and published some little case series, uncontrolled case series with using historical controls, showing how beneficial methylprednisolone was in very high doses. So we set up this placebo-controlled trial. I don't know how many $1 million it cost the NIH to do that, but it took us something like 10 years to enroll enough patients to get 30 placebo and 30 methylprednisolone patients studied, and it didn't work. And you can see the ribavirin trial that we tried to do in the United States and Canada, in 10 years of active enrollment in that study, I think we enrolled 23 confirmed cases. 10, yeah. So the challenge with an orphan disease like this is how do you know? There's just as an aside, there's one situation where that could only be done in Chile and Argentina, but if you have with household contacts, knowing that a small proportion of household contacts of a case are going to become ill, you could design a study where you monitored people by PCR, and as soon as they're PCR positive, throw something at them, and then see, treat 5 or 10 patients that way. It would take a long time, but you wouldn't need a placebo because you'd know that if none of them got sick, you'd know you had something great. But beyond that, I can't think of an easy way to do this beyond these massive controlled trials.
I'll keep kind of rapid fire asking you questions, Dr. Mertz, in the second time here. So there's a question in the chat about, are there risks of acquiring the infection from exposure to autopsy material from persons deceased from hantavirus?
I don't know of any cases of transmission, but I would use you know, I would, I would, I would take precautions in that setting, and we have it's one of the things that led to sort of BSL-3 level autopsy suites at our Office of Medical Investigator.
And Greg, along those lines, so can I also ask your thoughts about eye protection? I think the questioner was maybe focusing more on the environmental, exposure to rodents and rodent waste. But
Oh yeah.
yeah.
Well, yeah, no, I mean, because we assume it's all there. I think eye protection. It's the and this is more on the side of the health departments all have recommendations, but yeah, no, you should use eye protection. You don't want to do anything if you're cleaning it up that kind of stirs things up. So all the focus you'll see it. I'm sure your health department has the same in our health department. Probably it's all CDC based stuff, but basically you're talking about wetting it down, mopping, that kind of thing, avoiding sweeping, avoiding vacuuming in those settings where you have concerns.
Thank you. Hey, along those lines, I noticed you did not mention the possibility of sort of contact transmission, like contaminated hands to face or mouth, and I think CDC does indicate that as being a possible mode of transmission. Any thoughts on that or data on that?
Yeah, so there's very little, I don't know of any nosocomial transmission in the United States. In Chile, we recommend contact uh, uh, precautions. I mean, it's and people will in Chile, people mask and especially during, procedures and so forth, they're going to mask and use eye protection and so forth and gloves. Um, And but the only cases that appear, just two or three cases of nosocomial transmission. It occurred in a tiny hospital. Probably it makes I haven't been to that hospital, but it sounds like you guys are major medical centers there, and compared to this little hospital, and there were. So and no precautions were taken on those cases.
There's a question related to I think this, maybe Dr. Booth, this is probably a local question. Do we have the ability to do blood viral RNA testing?
No, all hantavirus specific tests are send outs. Basically it would be at the state public health lab. There are no point of care tests. That's why the 5-point screen is so potentially valuable when people are in the early cardiopulmonary phase.
We can do so. You could send blood to UNM to Stephen Bradfute, but the turnaround's gonna
Yeah.
turnarounds. They would do it as soon as I think they would do it probably if you talk to Stephen, he'd probably do it within a day of the time they get it. But you're still talking about a couple days before you're getting results back. So none of it's going to help you in the acute management situation.
We're getting close to wrapping up here, but there are a couple more questions, Dr. Mertz, if you're okay with
Sure.
rounding this out. Are there any studies of seroprevalence of Hanta antibodies in endemic areas?
Yeah, there are. So I haven't reviewed any of those recently, but I mean, so there's a big study in U.S. Forest Service workers that was done, and they had a very low seroprevalence. And this was back in I don't know about all these. I have pictures of our UNM field biologists dissecting Peromyscus back in the 80s and early 90s on a table where they're dissecting them on a table with and there's beer and sandwiches sitting on the table. I can't remember if they're wearing gloves or not, but I don't know any of them that ever got sick. And then in Chile, there are studies in Chile looking at seroprevalence, and it's very, very low. There are the higher areas were in some indigenous uh, communities in Chile where there were a lot of hantavirus cases, and there's some, a couple percent seroprevalence, as I recall. And I just can't remember the publications, but those are from publications. They're probably all now 20, 25-year-old publications. But the seroprevalence is very low. But in Panama, where you have a very mild disease, there are areas with very high seroprevalence. So that it looks like, there are with the choclovirus, which I meant to mention briefly, but with choclovirus in Panama, there's a significant seroprevalence in the population in that region. But people rarely die from it, and people get sick, obviously, but it's thought that with choclovirus, probably most people that acquire the disease have a febrile illness and never either don't seek medical care or it's not recognized as possibly hantavirus. They never end up in a ICU or anything and don't get investigated much. So probably most of those cases are either asymptomatic or just cause a mild febrile illness that gets missed.
And I'm assuming there was a related question, but it sounds like there's been no data on serology in high-risk populations in our local area, Dr. Boo, in the Eastern Sierra, like Mammoth.
Sorry, Adam, could you repeat?
So there's been no serology testing or studies done in our local communities over the years that you're aware of, have there been?
Correct, not that I know. No.
There's a question about, is there a website which tells us which hospitals have ECMO available? I'm not aware of a.
Well,
There is, yeah.
Yeah, that is in one of my slides, and maybe Tom, you've looked up that site, right?
I have. I don't have the the web address
Yeah,
immediately.
let me
But it's
go
easy.
back.
It's easy to find if you just Google for
But
ECMO
it
near
is
me
a,
or
I mean,
something.
it's a worldwide database. So,
It looks like
And I
someone dropped the link in the chart. All
and
right.
I and I and I was trying to find out in response to Greg's wondering about mobile ECMO, whether there was mobile ECMO available to us, and that's still unresolved. I had a couple of people were trying to help me find that information, but I don't have it. There was another question, Adam, about somebody asked about pediatric hantavirus disease. They had the impression that it's not very common in North America. They wondered about South America and also, in Eurasia, whether that form of disease is also relatively uncommon in children. Do you know that, Dr. Mertz?
so so it is uncommon before in pre-adolescent pediatric populations in the United States. It's also uncommon in Chile, but it's much more in Argentina, but it's much more common than it is here. And so there's one publication from Marcela Ferrez, Ferres, on on breast milk being implicated in maternal infant transmission to uh, some very young children that acquired some neonates that acquired it. And then in our prospective study, we had a 2-year-old. So there are pediatric cases there. And so it's more of an issue in Chile, Argentina than here. And fortunately, my collaborators in Chile were pediatric infectious disease specialists, so they have a number of publications on that.
We got to almost all the questions, but in the sake of time, I wanted to leave time for just any closing comments from Dr. Boo or Dr. Mertz, and a huge thank you on behalf of all of our communities out here and all of our organizations that support the health of our communities for you coming out today, Dr. Mertz, and
Sure.
giving us your time.
Yeah, I would just echo that. Thank you very much, Dr. Mertz. It's been very informative for me. Appreciate it.
All right. Well, thank you guys so much. Thank you, Barb, for setting this up, and everyone have a great day.
Yeah, thank you, Barb. Thanks, Adam.